Welcome to our Quality Assurance Review Conference, QUARK. QUARK is a quarterly grand round focusing on quality and safety issues that impact the care of patients within the Mount Sinai Health System. This conference has been a mainstay of our grand rounds curriculum over the past several years, spanning such topics as venous thromboembolism prophylaxis, improving handoffs between members of the patient care team, the aftermath of adverse events, and the Stop Sepsis campaign, to name a few. Today, we are pleased to feature Dr. Harry Cho discussing the implementation of high-value care. Dr. Beth Boucher, our Vice Chair for Quality and Clinical Affairs, will introduce Dr. Cho. Thank you.
Hi, good morning, everyone. It's my pleasure to introduce Harry Cho to you. Harry is the Director of Quality and Patient Safety for the Division of Hospital Medicine and a Senior Fellow at the Lown Institute, a think tank founded by the renowned cardiologist, Dr. Bernard Lown, who's committed to making patients safer as they travel through the healthcare system. Dr. Cho's research focuses on the relationship of overuse of resources to patient harm and bridging high-value care curricular with systems implementation with students, residents, and with faculty. Harry graduated from Cornell University and Temple University School of Medicine. He completed his residency at Yale New Haven Hospital, and since 2011, he's been a hospitalist at the Mount Sinai Hospital. Dr. Cho was selected as a clinical quality fellow for the Greater New York Hospital Association and the United Hospital Fund, and he's an active member of the Society of Hospital Medicine's Hospital Quality and Patient Safety Committee, and he's the chair of the Right Care Alliance Hospital Medicine Council. Additionally, he leads the Right Care Young Innovator Program and the dissemination of Right Care rounds, which are now implemented in over 60 programs across the country. For his efforts in high-value care, he's received several awards, including the Choosing Wisely Case Study Award from the Society of Hospital Medicine, the Teaching Value and Choosing Wisely Award from the ABIM Foundation, the Comcast NBC Universal Leadership Award, and the Top Hospitalist Honor from the American College of Physicians Hospitalist Magazine. Finally, Dr. Cho is a committed clinician, teacher, mentor of residents and students, and he's the unit medical director for Penn West. Harry, thank you very much for being our fourth speaker today.
Thank you for that warm welcome. All right, good morning, guys. All right, so implementation in high-value care. All right, let's go through this quickly. No disclosures. I have two things that I want to cover in this talk. Why is high-value care happening now, and how do we implement this? Pretty simple. Okay, a few graphs, and then we'll move on. Okay, so this is where our system is right now. This is the OECD data. This is about 3 decades worth, and as you're seeing here, okay, this is average healthcare spending per capita compared to wealthy countries. Okay, so this is the rest of the world, and as you're seeing this falling across, this is US, the black sheep there. We're spending a ton for our patients. Okay, more graphs. Okay, first in healthcare spending as percent GDP, annual per capita healthcare cost by age. I think we get the point here. We are spending a lot more than other countries. And I know what you're thinking. Well, you know, we are the United States. Don't we have the better doctors? Don't we have the best technologies and treatments available? Don't we owe it to our patients to spend more? Well, the outcomes should tell us otherwise. You can sort of read here. U.S. healthcare ranks last among wealthy countries, and they're looking at things like quality, access, efficiency, equity, infant mortality. Again, we're last here. Okay. This is another graph, life expectancy, just basic mortality versus healthcare expenditure over time. Okay. Again, we're sort of falling way below everyone else. So we're spending a lot, but our outcomes are worse. Doesn't quite add up here. Okay. So now we're looking at this. This is Time magazine. Has anyone ever read this? Okay, some hands up. So this is from Stephen Brill. I believe it's 2012. It's called The Bitter Pill, Why Medical Bills Are Killing Us. This is what brought this whole cost of care issue to the public fold. Okay. In it, it talked about things like gauze pants. It's $80. But following a patient's diagnosis of lung cancer, it was charged a $350 bill. This is normal saline. Yes?
Is there a way to tease out the cost of regulation and the liability issues related to healthcare? Because the other countries don't have those same issues as we have.
It's very true. It's very true. I just wanted to sort of get the basic premise. Okay? There is sort of analysis in terms of our overuse, in terms of our healthcare waste as analyzed. It is 750 billion in excess healthcare waste. It's a lot, but there is a lot to tease out there. But let me get back to sort of what we're talking about here. Okay, so this is normal saline. Again, $80 on our patient's bill. This is glorified water in a plastic bag. Chest X-ray, $330. Medicare rate is $23. Again, this is what patients are seeing on their medical bills. It doesn't make sense. It doesn't add up. This is the media, New York Times. They have a section, and one of the articles says this hospital prices soar, stitch tops $500. And this next one over here with BBC, this one came out a couple weeks ago. Real cost of giving birth, $40 to hold my newborn baby. And if you can see the medical bill right here, skin to skin after C-section, and then there's a cost for $40. It's kind of ridiculous, right? Just to hold your own baby after birth. This is kind of coming back to us. Well, let's put it to something that we can sort of relate to. If we are, imagine that you're done with your wards and then you're going off to a conference and you go to a Hilton and you're tired, take your shoes off, you want to lay down, you want to order some delivery and you want to turn on a movie. And there's this water bottle sitting on the counter. Is it complimentary? I don't know. That vending machine is 2 flights down. It's a little too far. Okay, so you grab the water bottle, you drink it, and you think, how much could it be? $5 at the most in a hotel. Well, what if you go down, okay, when you're checking out, and the bill says $90? How would you feel? I know how I feel. I feel angry. I get the manager. I start yelling at them. I say, I'm not paying $90 for this bottle of water. I probably go on Yelp. I write some angry sort of comment there. Okay? But this is what our patients are seeing. And so this concept of trust is changing. They used to say that when you're advertising a product or a service, that you wanted one of 3 types of people up there: a doctor, a nurse, or a fireman, to sort of earn that trust, sort of have that reliability. But as all of this is sort of going into the public's eye, their perception of us is changing. Okay? It's not, they want us, okay? They still trust us, but that's changing. Now, it's not, if you think about this other profession, it's not the police officer that you trust, that the public trusts. It's not the lawyer, it's not the judge, it's not the politician. I mean, do you really want this guy next to your product or service? And so that's where we are. This is a New York Times CBS News poll, how the high cost of medical care is affecting Americans. And they asked the question, do you think your doctor should discuss the cost of recommended medical treatment with you ahead of time, or don't you think that's necessary? 80% said that they should discuss. All right, well then here's JAMA. This is the views of U.S. physicians about controlling healthcare costs from John Tilburg. In it, they were talking about attitudes and responsibility about physicians towards sort of controlling healthcare costs. And 95% of the physicians across the country felt that they had at least some responsibility to affect healthcare costs. Okay, so at least we have that. And so now we're caught in this sort of eclipse. The healthcare system is not working. The patient is asking for us to discuss this and change this. And physicians are feeling more responsible about it. And so this is why high-value care is happening right now. So this is from Dr. Bernard Lown. It's one of my favorite quotes. He's talking about healthcare is doing as much as possible for the patient and as little as possible to the patient. And I always think of high-value care when I think of this quote. All right, so we're going to go into implementation a little bit. So 3 things to consider for improving value. 1, as much as people want us to discuss about costs, this is complex. It's too complex for us right now. Okay? Whatever, for example, if you order an MRI and you want to discuss that cost with the patient within the hospital, the cost of the MRI within the hospital billing is different compared to, and then plus the added part of the technician, the transport, the radiologist reading, myself reading it, and then conferring with other consultants, and then talking with the patient, and then them going home, insurance company going back and forth with the charge master billing, and then whatever the patient pays at the end is too difficult. There's no way that I can sort of relay that cost to the patient in an effective way. But talking about value is easier. Is this beneficial for you? Is this harmful for you? And sort of weighing the benefits and costs there. Okay. The second thing is clinician-patient relationship is key. We're not epidemiologists. That doctor-patient relationship is key. That's how we're training. That patient in front of you, that's sacred. Okay, that's who I want to take care of, and that's who I want to advocate for, and that's who I want to go all out for. What we can't do very well is think about the patient down at the ED and stewardship in terms of antibiotics or other things. That's not going to fly in my mind as I'm talking with this patient in front of me. So that's where we start to lose a little bit of sort of the buy-in. And the third one is linking overuse to patient harm. We respond to adverse events. If something has a potential to harm our patient, we're going to try to avoid that in any sort of way. Okay? But thinking about costs, just in terms of costs, is not going to really get that buy-in. Okay? I'm not going to give you this treatment because it costs too much and I want to save the hospital money. Physicians aren't going to rally behind that. So, but talking about patient harm and the adverse effects is. Okay. So when you think about overuse and high-value care, choosing wisely comes to mind. So this is from the ABIM Foundation. And what they did, this is about 6 years old, and they sort of had an initiative, and they said, you know what? We want to create guidelines, recommendations. And they created this Choosing Wisely top 5 list, 5 things physicians and patients should question. And they went to the societies. They went to ACP, SHM, SGIM, and so on and so forth. And they wanted certain things, 4 things they asked for. They wanted to choose care that is supported by evidence, not duplicative of other tests and procedures done, free from harm, and truly necessary. And they went to the societies themselves and they said, create that list. And so now 70 societies have responded, some with top 5 lists, some have second round and the third round. And they've been going back and forth. And what's really interesting is recently they've been having non-physician societies doing so. So this is nursing and physical therapy. It's becoming multidisciplinary. In the last couple of years, it's going international. So there's Choosing Wisely Canada, Australia, Wales just came in. Down below is Italy. And I believe they call it slow medicine. Don't ask me how that works. And then there's also Choosing Wisely Japan. So it's very effective. It's one of the most successful things that ABIM has rolled out. And awareness is definitely out there. But the next question is it effective? How effective is it? It's, again, 6 years old. Okay, this is from JAMA Internal Medicine, December 2015. Early trends among 7 recommendations from the Choosing Wisely campaign. So this is from Anthem, medical and pharmaceutical claims data. Okay, they followed it for 3 years. 25 million members there. Okay, they just wanted to see, you know, since the Choosing Wisely recommendations went about, is it really having an impact across? So here's the table data, and then what they found was that 2 out of the 7 recommendations actually found a benefit. Okay, lower utilization, imaging for headache and cardiac imaging for low-risk patients. What else is interesting is that was statistically significant, but there's 2 others that actually went worse, and then 3 that didn't change at all. If you think about it, 2 wins, 2 against, and 3 in the middle, not very effective there. Okay? So in the last year, ABIM moved from awareness to implementation. Because education and awareness is great, but to create sustainable change, to create lasting change, it needs a little bit more. All right, so I'm going to play this video. One, it'll give myself a break. But this guy, it's a very fun video. He has a friend who's an engineer, okay? And we like to think riding a bicycle is something that we can most of us can relate to. Okay? We do it when we were younger, and then it's sort of ingrained in us. And the engineer switched the bicycle around so that if you turn your handle to the left, the bike goes to the right. If you turn to the right, the bike goes to the left. It's just that simple change, and it sort of shows how difficult some of this is to follow.
Hey, it's me, Destin. Welcome back to Smarter Every Day. You've heard people say it's just like riding a bike, meaning it's really easy and you can't forget how to do it, right? But I did something. I did something that damaged my mind. It happened on the streets of Amsterdam, and I got really scared, honestly. I can't ride a bike like you can anymore. Before I show you the video of what happened, I need to tell you the backstory. Like many 6-year-olds with a MacGyver mullet, I learned how to ride a bike when I was really young. I had learned a life skill and I was really proud of it. Everything changed though when my friend Barney called me 25 years later. Where I work, the welders are geniuses and they like to play jokes on the engineers. He had a challenge for me. He had built a special bicycle and he wanted me to try to ride it. He had only changed one thing. When you turn the handlebar to the left, the wheel goes to the right. When you turn it to the right, the wheel goes to the left. I thought this would be easy, so I hopped on the bike ready to demonstrate how quickly I could conquer this.
And here he is, ladies and gentlemen, Mr. Destin Sandlin. First attempt riding the bicycle.
All right. So the faster I go, the better. Yeah.
I couldn't do it. You can see that I'm laughing, but I'm actually really frustrated. In this moment, I had a really deep revelation. My thinking was in a rut. This bike revealed a very deep truth to me. I had the knowledge of how to operate the bike, but I did not have the understanding. Therefore, knowledge is not understanding. Look, I know what you're probably thinking. Destin's probably just an uncoordinated engineer and can't do it. But that's not the case at all. The algorithm that's associated with riding a bike in your brain is just that complicated. Think about it. Downwards force on the pedals, leaning your whole body, pulling and pushing the handlebars, gyroscopic precession in the wheels, every single force is part of this algorithm. And if you change any one part, it affects the entire control system. I do not make definitive statements that often, but I'm telling you right now, you cannot ride this bicycle. You might think you can, but you can't. I know this because I'm often asked to speak at universities and conferences and I take the bike with me. It's always the same. People think they're going to try some trick or they're just going to power through it. It doesn't work. Your brain cannot handle this. For instance, this guy, I offered him $200 just to ride this bike 10 feet across the stage. Everybody thought he could do it.
No, you didn't understand. You didn't understand. So, this way. Okay, all right, a second. All right, so, whenever you're ready. Yeah. Wait. No, you have to keep your feet on. Dude, all right, here we go. Wait. Like, you gotta start rolling at least. And go. Oh, go! All right, back up. Okay, go. Keep your feet on the pedal. Go. Go right on. Just keep your feet on the pedals. Tails on. Yeah, come on. All right, one more time. Okay.
Once you have a rigid way of thinking in your head, sometimes you cannot change that, even if you want to. So here's what I did. It was a personal challenge. I stayed out here in this driveway and I practiced about 5 minutes every day. My neighbors made fun of me. I had many wrecks, but after 8 months, this happened. One day I couldn't ride the bike and the next day I could. It was like I could feel some kind of pathway in my brain that was now unlocked. It was really weird though. It's like there's this trail in my brain, but if I wasn't paying close enough attention to it, my brain would easily lose that neural path and jump back onto the old road it was more familiar with. Any small distractions at all, like a cell phone ringing in my pocket, would instantly throw my brain back to the old control algorithm and I would wreck. But at least I could ride it. My son is the closest person to me genetically, and he's been riding a normal bike for 3 years. That's over half his life. I wanted to know how long it would take him to learn how to ride a backwards bike, so I told him if he learned how to ride a backwards bike, he could go with me to Australia and meet a real astronaut. Are you gonna give up?
No.
Go ahead. This is how it starts. Look at this. This is such a big deal. Get up, you got it. Did you see his brain get it? So he, in, how many weeks have we been doing this? 2 weeks? In 2 weeks, he did something that took me 8 months to do, which demonstrates that a child has more neuroplasticity, am I even saying that right, than an adult. It's clear from this experiment that children have a much more plastic brain than adults. That's why the best time to learn a language is when you're a young child. All right, today's bike log.
All right, I'm gonna stop this. So you get the point here. So the rest of the video goes on where he actually relearns the other way, okay? And it takes him a while to actually get that back. But it's interesting, right? This whole concept of unlearning what we've done before. If you think about all of that we've done, okay, in terms of your clinical care, whenever you have someone come in with shortness of breath, what thought process comes to mind, no chest pain, what differential, what testing to do, who to call. All of that is years and years of training through medical school, through residency, through all these CME courses and sort of clinical care. That takes, it's not like we write this out or sort of draw it on a map. It just happens. So to unlearn some of this process takes time and it's difficult. So I wanted to do that, okay? But where do we start here? So if I wanted to change high-value care, here's where I started, okay? In order to implement this, I think what I wanted to do was take sort of education and quality and safety. In terms of education, sort of a few years back, it's sort of the ACGME demand in terms of what they wanted for high-value care education. People didn't have resources to do this, and so this was an opportunity. And the other side was sort of the hospital and the healthcare system, and sort of all the oversight sort of bodies over there. And so where do we find that how do we cover both? And that's where I started. So this first one is Occams conference. So this is, it's a group of us that developed this, but I spent most of the time with a medical student, he's a fourth year, Carlo Lutz. He's now an ED physician, or ED resident. So this is an acronym, it's Overuse Clinical Case Morbidity and Mortality Conference. And it's named after this guy, 13th century logician, theologian, and philosopher, William of Occam. He's best known for Occams Razor, which is a principle of parsimony, economy, and succinctness used in problem solving. So it's that saying, when you hear hoofbeats, think horses and not zebras. It's that heuristics, that way of thinking, and it works really well for overuse. So we did this, I believe it was a couple years ago, and what we wanted to do was create a conversation piece, okay? So have our trainees, our students in one side, have our administrators come in, our attendings, to sort of connect the dots and have that conversation together about overuse. And it's very interesting. You know, the cases that we talked about was cases of overuse that led to a harm, something that we do every day, okay? So in this one, this is Masha Jones, again, a fourth year medical student at the time. So she had a case of a patient who had, it's a woman in her 60s who had asymmetric hearing loss, okay, and it was prescribed valcyclovir, prednisone of 60, and that prophylaxis PPI, just for 2 weeks. Relatively harmless in hindsight, at the time, okay, it's something that we sometimes do to sort of prophylax for that stress ulcer. And what she ended up having was a reaction, a drug reaction, where she had urticarial hives and everything else, and she got hospitalized for a short time. So she wrote about this in JAMA Internal Medicine Teachable Moments. And this is sort of what we're trying to capture here. Everyday things that we take for granted that isn't evidence-based, but we do it, but it does turn into harm. This is what we need to see at this point. So we take those cases, and in effect, Occam's conference was like this, and I think most of you residents have at least been to one of them. So you take that overuse case, you take sort of the format of the M&M conference, which we are familiar with, okay, but in a safe and effective way so that we can have a conversation, a safe atmosphere. And then the RCA group, or the root cause analysis work group, that actually looks at it from a bigger scale and says, can we sort of make this a little bit safer in a bigger scale? And so Dr. Jagendra leads that, and so that's what this was made of. And then we needed a tool, and we took this fishbone here. This is the Ishikawa diagram from the 80s, and we wanted to sort of have systems processes in place that worked well in the healthcare system and in other places. So we took it from the Kawasaki shipyards and the principles of machine, materials, methods, environment, and manpower. And then we took in this, because it's not just systems issues, it's also sort of the drivers of overuse, the everyday things, okay? It's the time pressure, it's the patient demand, it's that fear of repercussion. And we created this modified fishbone, and this is what we have here, okay? Again, this is sort of a basic fishbone here, but on the top we have this drivers overuse to at least discuss, okay, and go over the definitions. This hasn't really been done before, and then on the bottom is the system-based factors. I got this off of Mark Bonacek. He's a great speaker. This is from the early 1900s. This is the horseless carriage. If you look at this picture, it's very interesting. So this is the prototype for a car, okay? But if you look at the handle right here, this is a crank bar. They got this out of a steamboat, okay? this is a carriage that a horse would drive, okay, but it's horseless. So people have a hard time relating to new things, and when you're venturing into sort of new territory and creating things, you take things that worked from other places and you sort of mash them together. And it's hard to sort of recognize at first, but this is kind of what it is. And sometimes when you're creating new innovations, sometimes it looks a little bit mashed together, but it takes time for people to understand that. All right, so the next thing that links education to implementation is the Student High Value Care course. Again, it was a medical student. You see the pattern here? Medical student came with me during a summer, had some time, and said, I want to get involved in projects. We sat there together and we said, okay, well, what can we do? We sat here about trying to formulate a different plan in terms of creating things. So we used the model from UCSF in terms of a high value care committee that worked well. So we had the model for for faculty. Second part was with residents. We had a model to create projects and to create systems change. Well, we didn't have it for students, and it wasn't out in literature, and said, well, let's do this. Okay, let's change our model for the high value care committee that we have with faculty. So we sat down, and honestly, I wanted 2 students involved. And we sent out a blast email, and we said, send an email of what you've done before and why you want to join. And we got over 20 students to reply with long emails, very heartwarming plea of wanting to get involved. And I realized something. That's untapped resources. That's untapped potential there. Those are students who are eager to get involved in this. That's something that we needed to get into. And so we decided to sort of create a little group in itself. So this is Dr. Getz. She co-directs this, and she does a great job with the curriculum. So this is our second year, okay, with the medical students there. These are mostly first and second year. It's a Nexus course at this point. But what we wanted to do was we wanted to create change. In order to do that, we break it up into teams. So we did that, and we got our faculty involved. Faculty want to work with some students, get some experience in mentorship, and then the students obviously want some faculty mentors to sort of learn and grow and do things together. So up in the teams to do some research, here's some low-value things that are going on, pick a project together, and then formulate a plan. And it sort of happened. And we focused on 6 things here. One is we wanted student leadership to sort of move this along. Okay, this group of 20 or so that we had in the beginning. So we created a co-chair with John DeCapo and Irene Lee. Again, they're currently second-year medical students, and they're basically running the ship here. We wanted to create a peer learning group because if you want to talk about high value care, you want to have a lot of people who talk about the same thing next to you. It makes it more exciting. Faculty mentorship, as we talked about with hospitalists, the institutional support. This is where I come in. This is where Beth Raucher and Andy Dunn come in, where we try to help out as much as we can in terms of resources, data, sort of introducing them to our nursing staff and saying this is a priority. We had to teach this, how to implement improving value. It's not out there. So we use QI methodologies and sort of curriculum with leadership and scholarship curriculum sort of mixed in there. And we created sort of a vie for scholarship, and we created a longitudinal project. And the website and the Twitter. And in December, we wanted to get institutional buy-in, so this is our pitch day. Okay, think of it as Shark Tank. Okay, here's our administrators and faculty, okay, who are eager to sort of judge, and here's our student in front giving a 5-minute presentation about what their project is and what they want to do and why it's so cool. Okay, and they did it in front of their students and their faculty and our hospitalists and our nurse practitioners. And it was a great event, and it sort of brought everything together in terms of what we're going for. And house staff, this year, you guys are going to be invited also. All right, so let me just draw it out on a map because I think it'll be easier. So if you have education and implementation there, this is our faculty, our high value care committee, and sort of the projects that we started with right here. Okay, this is our house staff. Okay, this is our Occams conference, and sort of it bridges between education and implementation, and again, sort of the projects that come out of it. And then this is our medical students with our student high value care course. Okay, this is our first 3 projects, and then our next 4 are just starting out right now with 4 different. It's a lot. Okay, it's a lot behind this, and it took a lot of time to make this happen, but it looks like people are eager to do this. So why not? All right, so we'll talk about one project here. Let me just check on the time. Okay, so this is the Foley Project. again, student-led, faculty mentor with Dr. Getz. All right, but Folate testing, I think this is a classic example. So this is a Journal of Hospital Medicine, and they looked at serum from Beth Israel Deaconess. They looked at 1 year, I believe it was 2011. They wanted to see all this Folate testing that we do. Anemia, altered mental status, neurostatus changes, what have you. We order a whole lot. Are they really coming back low? So they wanted to check it in ED, everywhere else, okay? 2,093 checks within the entire year, Beth Israel Deaconess. 2 of them are low. Okay, if you do the math, it's 0.1%. That's rare. I sometimes use this as an example of the difference between low value and no value. Okay? And let me just put this to a reference point. That well score that you guys use for PE, risk stratification, just to whether you want to do the CT angio or not, those 7 questions about tachycardia, leg swelling, all that stuff, if you get all of them negative and you get a score of 0, still gives you a 1.3% chance of having a PE in the ED. We don't order CT angio when it's 0 points. But here's Folate, 0.1%, no rhyme or reason, and we were averaging 17 orders per week on the hospice group alone. All right, well, more evidence, okay? If you don't believe that one, American Journal of Medicine, Hospital Medicine again. Here's JAMA, outpatient, 11 years, 0.05%. Folate has been mandatory fortified in the US since 1998. We've sort of outgrown it. But we check it religiously like it causes everything. So this is the student group. I said, well, how are we going to create awareness? How are we going to change this? So they gathered with these small cereal boxes. This is their idea. And they said, you know what? How do we replete Folate? Put the box of cereal. So they wanted to use this, and they called their initiative sort of "Don't be a cereal orderer." Okay? And so they made these cereal boxes with a little sign in it in terms of in terms of repleting it and sort of what to do with the orders. And they went to the house staff at their change of shift, at their handoff, early in the morning in February, and they started doing this, handing cereal boxes. If you think about this, here's a first-year medical student with no clinical background, okay, going to house staff and faculty members. You can't get angry at this. They're just handing you cereal boxes 7 in the morning. Okay? With a catchy slogan, and it's real, it's student-led. And this is what we're seeing. Okay? Here's the pre, here's the intervention, here's the post. Okay? 17.5 labs per week, it's down to 11.5. We have a 34% reduction just with education awareness alone. Now, obviously, we need to lock it in, and as of this point, B12 and folate, I think this was the issue. This was in the back of the cereal box. B12 and folate were sort of tied together, so if you wanted to check B12, which needs to be checked at some times, okay, we just need to separate that, and we just did that within the last couple of weeks. And so if you look at the data here, right there is when the intervention started. Okay, the purple line is vitamin B12 orders, and the folate is the blue. But you see how it sort of separates? There's that gap in between. Okay, folate's going down and B12's there. That's the culprit. Okay, but we're still ordering folate. We're still averaging. I don't know how this is slipping by 11 tests per week. We're going to track it down, but it's helping. And the charge master cost for this is over $100 per test. Okay, it's not benign, and you don't know what that's going to come out to. It may be harmless just because a consultant asked you, but come on. All right. Next one is CBC. I could keep going on and on, but I won't. This is choosing wisely recommendation, number 5 from SHM. Don't perform repetitive CBC and chemistry tests in face of clinical and lab stability. This has been criticized a lot, and calls after calls I do with research groups in ABM. The one question that they have is, what the heck is clinical and lab stability? How do you create guidelines for that? The other recommendations that they have for removing Foleys has a clear guideline from the CDC. Telemetry monitoring has a guideline from ACC and other cardiology societies. All of these have sort of strict criteria in terms of when to do it and when to not. This one does not. If you think about our teaching, my service alone, if you think about this, right? Someone with a pneumonia doesn't have pneumonia. They have other things. They have end-stage renal disease. They have anemia. They have COPD on top of it. And depending on what time of what time of the hospitalization in terms of which severity. What the heck is clinical stability? You can't create guidelines for this. Anemia isn't enough. Okay? Electrolyte monitoring is not enough either. So this is tricky. Okay? There's been a lot of literature within the last year, about 7 or 8 articles coming out. But this is from this is Dr. Sega and Dr. Alberti. So we're looking at this in KCC 4 and 5. This is ADS hospice units. Okay? Here's the baseline, and here's the post-intervention. You can sort of see this nice going down if we just kind of draw it out. Okay? So far when we did this, it's 70.7. It's about 8% reduction. It's p-value of 0.002. Okay? That's great. Okay? Other places have done this, and I think we're publishing on this, but I think the 2 very interesting things. One is, oops. Well, let's cover this. Okay? So I was on the house desk team maybe about 4 months ago. We got a transfer from the surgical unit. It's a woman in our, who's middle age and had necrotizing fasciitis and had renal failure on top of it and got transferred over. That bugged the crap out of me. You know, I once sat down next to a patient. I just kind of sat there. We wanted to just talk. And I asked him, I was like, you know, you're going to be here a few days. Could you do something for me? Could you tell me how this whole lab draw happens in the morning? He's like, sure. Okay, he's around his 60s. He's ambulatory, but he was here waiting for a placement. And so he told me sort of this process. 4:30 in the morning, someone comes by and just sort of scans his little code and then walks away. And then about 30 to 45 minutes later, they'll come back and sort of do the lab stick. Okay? And he said yes. He's like, do I need this lab draw? Well, who's doing the lab draw? It's not one of you guys. It's the PCA. Okay? They can't answer this question. Okay, so the response that he got was that, well, the doctor ordered it. Well, they can't have a conversation. It's also 5 in the morning, so are you going to call the cross-covering intern overnight that's cross-covering everyone, doesn't have a good idea? So this is where the breakdown in communication happens. And so the patient just learns to sort of trust in the order and just gets stuck. And this is a blood draw. This is not, it's a sharp object going through your skin, causing pain, you lose blood, and here, with our system, it's automated. This is 2 years worth. I don't know, I just thought this was ridiculous, so I just wanted to go on about it. All right. But in sort of light of that, okay, this is a paper from NYU Langone. They are one of the few, I think, that actually tried to limit this. Okay, so they went around with their EMR system and they said, you know what, we're not going to do any repetitive labs. We're just going to draw the line. We're just going to do it. Okay, so it was top down. They got some sort of heads there, and they made that thing, or they made that sort of a change. And from there, every single lab draw just went down. And that 100 weeks of consecutive lab draws is very common. In my unit, when I do a cross-sectional check, I say about 60% have greater than 1 week at a time. Okay, so it's definitely there, it's definitely automated, and it's thoughtless. But it works if you sort of limit it. But what's cool about Dr. Sega's initiative is, one, the question about clinical stability. The one time that we all sort of agree is when the patient is ready for discharge. Okay? At some point, with everything going on, at some point they're going to be stable, ready to go home. We can figure that out. Okay? So the thought is, why not go from backwards, okay? From the point of discharge, and we'll sort of work our way in. Because the day before may be closest to clinical stability that you're going to get. And so, so this is Josh Funt's work here. Okay? We looked at sort of the number of labs and 24 hours before discharge, 48 hours before discharge, 72 hours before discharge. And that's the way that he worked, with the IDP order, okay, in a multidisciplinary format where anyone can chime in. If that order is in, does the patient need labs? Pretty reasonable. I think it's very innovative, and we haven't seen that yet. And I think this is a great idea of how this goes. And you can see that the greatest drop is 24 hours, and as you get towards 72, it's becoming less. But that may be the easiest way to do this. The second part is those two units are very interesting in the sense that the multidisciplinary rounds are actually held at the bedside with the attending medical director, nurse manager, and a nurse. And the patient's right in the middle. And they discuss this the necessity for labs for tomorrow right at the bedside with the patient in the middle. You don't see that anywhere else. And so I think that's worked well. So we're doing this in Time West, and I see Suzanne in the back over there. This is the student group sort of working off of this. This is a different team. Okay, and we have these little signs here, sort of attending there. Okay, it's a pretty crude sign, but we have our attending sort of asking, does my patient need labs here? Okay, sort of getting the buy-in from everyone. And what we're going to do next, because 10 West, the teaching units are much more complicated. Okay, KCC 4 and 5 have one hospitalist and maybe one or two nurse practitioners sort of there on a daily basis, and that hospitalist rotates every couple weeks. You just need to talk to one doctor. That's it. Okay, and Dr. Shimwa is sort of running this, and you can imagine how many house staff run through in a given year. There's 100 of you. Okay, some of you coming from psych and ED and anesthesia, and it's hard to really sort of educate, implement, and sort of create that lasting change. And it's difficult for communication to happen. And so I think our next plan is to try and make this sort of connection between the PCA and the nurse to the physician in order to sort of lower this. All right, so let's go back to this map here. This is a lot of projects, okay? Each one of these has a faculty lead, a mentor, resident, if not multiple, and multiple students. And this is all of them, okay? Sort of running through. If you think about how many people this is, I sort of did a mental count here. It's about 12 faculty. There's over 50 students. I don't know how many residents. I've sort of lost track over the years in terms of how many people are involved. That is a small army. Okay? It's hard to create that. Everyone's sort of working together to create one thing here. It's interesting. I talk with some other groups in terms, UCSF and Hopkins in terms of they have a similar model in terms of high value care. And I think this is where we differ. We have a group working together to try and create this change. All right, this is Diffusion of Innovations from Everett Rogers. It's more of a business model, but I just wanted to apply it here. Okay? So this is when a new product or new innovation comes in, and sort of the time course and the course in which it gets accepted. Okay? So this is the innovators. This is the 2.5%. This is the early adopters, about 13.5%. Early majority is 34, late majority is 34, and then you have the laggards, which is the rest of them. If an iPhone came out tomorrow, okay, the innovators, the 2.5%, are the ones who are eager. They'll be lined up the night before, waiting to get the first one. These are the ones who are just jumping on the bandwagon to test it out because they're excited, because they want to get involved. The laggards are the ones who aren't using smartphones. They're using it because the button phones are gone. Okay, those are the late adopters. Sometimes that's me. Okay, I was just telling Dr. Raucher that whenever an epic change happens, I have to sort of flag the email, reserve about 20 minutes, and just kind of mentally prepare myself and to try and change this. There's a lot of changes that happen, but those are laggards. And here, in order to sort of get from the innovators to early adopters, this core group, this is where they say, right around there, 15 to 18%, that's where they say we need to cross in order to sort of push this over. That's the big hump. And once people latch on, the early majority and the early adopters, they're the ones who are looking at the ones who used this before and saying, how'd it work? Is it cool? Does it work? So this is where we need to go. And it's interesting because we have this large group, this large group that's actually working together. And so whenever someone wants to do something, okay, for example, if it is Folate or daily labs or ultrasound and cellulitis, every time someone wants to do this, we have a team. Okay? We sit in the same office, or the student is in the same class, and they say, oh, you know what? My colleague over there, or my classmate over there is working on this project. We shouldn't do it. This sort of spreads very easily, and so that hump is easily crossable. Now this is in Pennsylvania. This is Amish. This is called barn raising. It's very interesting. When they want barns to be built, they don't call a construction company. Okay? The neighbors just sort of come together down the street, across the street. They just kind of come together and build a barn together. It's very interesting. It's almost just teamwork, just come together to create something that's needed. And I think we're getting there. We're getting to this hump. And this is what we need to sort of make these changes happen. We can use all these strategies of implementation, and a lot of these have them, right? You can do the education, you could do the awareness, you could do the targeted feedback, EMR changes, checklists, what have you. All of these are multifaceted, multidisciplinary. You can do these over and over and over again. But the big change here is to sort of create this conversation and create an avenue for this. That is hard to change. There's a survey out from New England Journal, Catalyst, and they asked if a new administrator comes, what the expectations are, what do you hope for? And the first thing that pops up, about 50% of the people said they will expect them to change the culture. How do you do that? And I see Beth Roucher laughing. Yeah, how do you do that? Well, it's difficult. But I think we're on the brink of something here, okay? Because we have a group of people who are working together for the same thing. I'm going to end with this slide here. One of my favorite ones. Strategy or not, okay? This is a culture eats strategy for breakfast. Whatever you put in there, whatever the culture of the group, the hospital, the unit is, it's going to overtake it. Even if you limit that daily blood draw to 1 unit or 1 order consecutively, people are still going to find ways around it. Okay? All right, that's all I have. Thank you.
Thank you. Any questions for Dr. Chen?
So it's obvious that anything that you're told by somebody who's older and wiser may not be true. But how do you teach people when they should question and when they should accept?
I'm sorry,
You
could you
can question everything all the time, but that doesn't get you very far.
I'm sorry, there was a little bit of rustling there. So the question was,
The question is, how do you teach people how to know when they should question what they're being fed by others?
yeah, that's tough. That's tough. You know, Choosing Wisely Canada actually came up with a list. They went across, they apparently only have 17 medical schools across the country, and they created this list with their sort of student society. And it was interesting, their list. It was, I can't remember verbatim, but they were talking about things that students can do sort of off the hand. And they said, when, for example, when there's sort of a less invasive test as an option, you know, definitely suggest it, or raise your hand if you have a concern. Something along those lines that are very blanket, that aren't very targeted. I don't know. I don't know how to answer your question.
I'd like to return to your first slide,
Sure.
which talks about the cost of medical care. And I think what you're doing is important and worthwhile, but I'm concerned that the growth in the cost of medical care may not reflect what we as doctors do specifically. There are 4 areas that are included in that, I presume. One is the cost of drugs. Second is the durable medical equipment business. Thirdly is physical therapy. And fourth are visiting nurses services. All of those have grown tremendously in the past number of years. I think you have to parse out the cost of each of these things and say, okay, this is what's really driving this, and then focus on that issue in terms of bringing down that number.
Yeah, you raise a good point. I think Berwick sort of created this model in terms of categories of overutilization of where our waste is coming from. But you're right. I mean, there is definitely things that we spend a lot on that is actually helpful. But we know that there are pockets of waste and overutilization, whether it's administrative burden or, you know, unnecessary testing. There are pockets there that we can sort of focus on.
There was an article that I think Harry shared with me that said that doctors do control about $700 million worth of waste. You're absolutely right. Pharmaceuticals are very, very expensive. Services after hospitalization are very, very expensive. Home care services are very expensive. But we still, and we can share this article with you, we still control over $700 million worth of what they consider waste in those figures. So there's a lot we can do.
Yes.
Do you look at the chances of any of the numbers of projects that you have being memorialized and the cost and risks of memorializing a project? That is to get it, find the problem, and get a fix implemented, and get the fix memorialized so that it actually stays there.
Oh, you mean sustain?
Yes, sustain. There's a cost of sustaining all these things. When you analyze a project, you look at that.
Yeah, that's always the trick of QI, right? Is how to create that lasting change whenever residents sort of, where a faculty member comes and then leaves. How do we keep that in place? That is always the trick. I think one thing that we always default to is the EMR system. That's always in place. Okay, that is something that we sort of stare at for hours and hours of our day instead of sort of what we really want to do with being with our patients, but also sort of the structure of the unit and sort of the workflow itself. But it's difficult. It's not an easy fix there.